Welcome everyone to the 2022 Sibley Lecture. I know many of you, but we have quite a large number of guests joining us in our live stream. For those I don't know, I'm Jonathan Shervino. I'm the Assistant Dean of Merit. This is an annual event and our first in-person rounds in more than 2 years. So we have many reasons to celebrate, not the least of which is we get to see real people, our friends and our colleagues again in real life. And I think for that alone, I'm pretty excited about today. You're going to hear more about Jack Sibley in the Sibley Award and the Sibley Award winner at the conclusion of our presentation. This in-person event and the award is through an endowment offered by the Sibley family. And we're very pleased to invite and to have present to us today the 2022 Sibley lecturer, Dr. Brian Hodges. Brian will be known to many of you, and if you don't know him, he's had an incredible career as an educator, as a clinician, and as an administrator. He's currently the Executive Vice President for Education and the Chief Medical Officer at the University Health Network and Professor in the Temerity Faculty of Medicine at the University of Toronto. Brian is a practicing psychiatrist and teacher. His research and writing focuses on assessment, competence, compassion, and the future of health professionals. Brian earned an undergraduate degree in psychology, followed by an MD at Queen's, for which we won't hold him against that. He pursued a residency in psychiatry with serves him well in the field of health professions education and a fellowship in medical education at the University of Toronto. He has a master's and subsequently a PhD in education at the Ontario Institute for Studies in Education, Toronto, with a subsequent degree in health economics and social sciences from the University of Paris. Dr. Hodges is going to be speaking on caring, compassion, and learning in a hyper-technological age. It speaks well to our in-person and our live stream of the 2022 Sibley Lecture. Dr. Hodges.
Thank you very, very much. It's really strange to be back physically together again. It's strange good, but it's strange. And I was so pleased to be asked to, first of all, just to come. Thank you very much to talk to you, but also to talk about that, getting back together and virtual and live. And for those who are joining us, this is a perfect example of our new hybrid world. So I'm actually going to put this on. It's really a talk that's not hyper academic, but designed to stimulate some thinking and to actually get you to think a little bit about what we've been through. I am a psychiatrist, and we've been through a lot, and we're still going through a lot. And I want to just honor that as well. Minor disclosure, they don't give me very much money, but I do have a relationship with AMS Healthcare, which is a charity that some of you probably have a relationship with. They give out a lot of fellowships and whatnot, but they did ask me to help curate this book and edit it. It's called Without Compassion, There Is No Healthcare. And there's a fair bit of content in this talk based on the book. And I think some of you, I know some of you are active on Twitter. So for those in Cyberland and here, if you want to connect, we can do it that way. I find it more straightforward. All right, so let me start with technology and what's happened to us in the last period of time. And I would say this started pre-COVID. So the first observation I would make is that competencies to be active in healthcare have changed quite dramatically in the last little while. And I'm going to just pick out a couple in technology first. I want to talk about technology before I talk about compassion. In fact, it may be strange for you to think about compassionate technologies. So I'm going to break it down a little bit. Let's talk about tech first. So medicine is going virtual. Medicine is going digital. And when I say medicine, I don't mean doctors. I mean the practice of health sciences. Now, what do I mean by technology? Technology is a word that's used for everything, and the risk is it means everything and nothing. So I have a very simple understanding myself for what I think of as technology. Technology is something that extends or augments a human capacity. It's a simple definition. So my voice is great, but it's not what it is when it's amplified. And my eyes are great, but without my contact lenses or my reading glasses, I can't do as much. And so humans have limitations, and technologies amplify those. If you think about technical skills, I have very chubby little fat fingers. I do. I'm sorry, that's how they are. They came from my mom. I love my mom. We have the same hands. If I stuck these inside your brain to do neurosurgery, we'd be in big trouble. It would be like an avocado getting fingerprints in it. And so humans are full of limitations. We have great skills, but we have limitations. So dexterity is another example where we've invented tools. Anyway, the bottom line of this is that my simple definition of technology is anything that extends a human capacity. So how are we extending the human capacities we have now, and what is that doing to technology, to competence? This is Catherine Gray. She works with me at Michener Institute. She's our disciplinary head for chiropody. And I think chiropody, of all places, is one of the areas where you can see very radically the impact of technology on how we diagnose. This is an app. Many companies make these now. This is the Swift app, where your cell phone has a sufficient pixelization to take a picture of a wound, and it can tell the vascularization, and with an AI platform, determine for the user whether this is likely to heal with conservative treatment or whether it's urgent for an amputation. In the hands of a personal support worker in a long-term care home or a shelter worker, you can make the differentiation between a wound that will heal and an amputation. Ontario has the highest rate of amputation in the Western world. We amputate a limb every 4 hours, and 85% of those are preventable. So the technology to incorporate artificial intelligence in the hands of a frontline health worker is really a transformational competence. This is Heather Ross. She's a cardiologist who works with us at Toronto General. And Heather is a leader in how we are changing how we provide care. This is the Medley system. This is a system using technology, digital and AI, where patients at home with congestive heart failure can enter their own data and can monitor with sensors. And the system, one nurse per 300 people, monitors so that they, rather than coming in and having your 5-minute appointment and paying your $25 parking and all of that, it detects if your weight has changed, and it will automatically adjust medications and the digital prescription to the pharmacy, which will deliver the medication that needs to be changed, for example, or monitored by a nurse practitioner. This is Amin Mandani, known to some of you. He's a fantastic surgeon who is working on how we augment how we see. And in surgery, we're getting to the place now where it's going to be standard very soon to overlay AI-assisted vision into the field of the surgeon working with laparoscopy. I've even seen versions of this now, like Google Street View, where it has arrows that says, don't cut this. This is I'm a psychiatrist, it's a little more sophisticated than that. But it overlays their neurosurgical models now that overlay AI vision on top that says this might be, this structure may do this, and guidance. Like I back up my car, and my backup car is a technology. Cameras help me. This is going to be normal. This is a competence that we're all going to need. This is our pharmacist leader, Emily Musing, and Emily's made it very clear that it's no longer competent anymore to calculate drug dose interactions in your head. I don't know if it ever was, but this is not something the human brain can figure out on its own. And so the competence to actually ensure safe prescribing now requires technology, augment our thinking. And this is my colleague now at CAMH, Sanjeev Sakalingam. Psychiatry has been one of the most radically transformed by the arrival of bots. And we have to teach people how they can use chatbots, often with AI, to augment therapy. That is a whole ton of competencies that were certainly not taught to me in medical school, but we weren't even teaching them 2 years ago before COVID. So prior to COVID, I did a lot of talking, or was invited, I did a lot of talking. Yeah, I do that too. But I was invited frequently to talk about how technologies will transform care generally. My main point is to go to compassion, but before I do, I want to make sure we understand what we're talking about. And that is that whether you're a doctor, nurse, physio, pharmacist, chiropodist, our practice has been and is being radically transformed by technology. The question for today is, what will that do to our compassion? Are we going to provide more compassionate care as a result? Or are we going to provide dehumanized, machine-based, distant, cold care? So we need to talk about what compassion means with technology. Most of you will have a sense of what compassion means generally, although I'll give you a definition. But what does compassionate technology mean? There's a lot of hideous technology that is really not compassionate. So first of all, I'll give you a definition. Compassion is more than empathy. Empathy just means that I understand the experience someone else is having, or I try to get as close to it as I can. I can watch the war in Ukraine and I can feel empathy for somebody who's lost a child or who has been injured, or that's empathy. But compassion is doing something about it. So in healthcare, empathy is not sufficient. In fact, empathy may be a problem. There's some books being written about how empathy may interfere with our ability to act. So just feeling something isn't really all that useful. It's the first step. You have to be able to feel someone's emotions or suffering or understand them. But it has to be coupled with a desire to do something about the suffering before it's compassion. This is the definition we use in the book. So now it's more complicated. So now I'm talking to you about technologies that allow you to act on your compassionate impulse. Okay? So what is digital compassion? What is that? Anybody have any idea? This is a chapter in the book you might want to look at by three amazing authors. David Wilgers, an IT person with a degree in classic studies. Gillian Strudwick is the chief nurse at CAMH, and Alison Crawford is a psychiatrist who teaches about arts and humanities. But they've written this brilliant chapter, I think, on digital compassion. But what is it? What do you think? Anybody want to try? Teresa, what do you think digital compassion is? Okay. I like that. The way we can build digital interfaces that allow caring to occur. That's a great start, because that's what I said about extending the human capacity. So if the technology extends or builds on our ability to make a link, a compassionate link. That's a good definition. I like that. We'll stay with that one. Thank you. This is a diagram that's very simple if you want to put it in frameworks. We all like our competence frameworks. I think that we need to know about how technology works. There's a body of knowledge. We need to know how technical things work, but we have to integrate them in health sciences. This is the thing, the health sciences, that's why the book's called Without Compassion, There Is No Healthcare. It's not just knowledge and skills, it's integrated with a compassionate focus. But every technology distorts. Every technology distorts. So when we choose to amplify or augment or enhance, the risk is we distort. So voice amplification, yes, good, have a microphone, but there's always the risk of static, screech, etc. Vision, blurring, skewing, changing, visualization. The folks that are watching me through this tiny little camera on top of here, I mean, hallelujah, amazing, right? They can do that at home and they can watch me. I don't know what they're seeing. I actually was watching a friend during the election. He was one of the commentators, and I texted him. I said, "Oh my God, Rupin, like something's sticking out of your back pocket, and all I can see is your profile. Can you fix that?" And he went to the bathroom between. But the camera was picking up, not right. I just saw a colleague at a meeting who hadn't met, and he said to me, "Oh my God, Brian, you're three-dimensional." Right? Size. Somebody said today, you see people you've never met except on Zoom, and you realize, oh my God, you're huge, or oh my God, you're really small, or wow, So it's distorting, highly distorting. And of course, tools, if you're a neurosurgeon or anybody and you're using tools, those tools are wonderful, but if you use the wrong force, or you can rupture things, or you can lacerate things. So what about the distortions of digital compassion? So go back to Teresa's definition. If we say digital compassion is using a technology to amplify a human quality, then we would say it might do these things at the top. It might enhance our physical presence. It might augment our availability. It might allow us to listen better or more deeply or understand more. It might allow us to reduce the inconvenience or distress of a situation. It might amplify our expressions or our patient's expressions or gestures, but it might also worsen the relationship. And there's a lot of technologies that have risks that I think are really critical that can worsen relationships. And you've just lived through 2 years of these, and I think you know what some of those are. I'm going to argue in a few minutes that as educators and clinicians, we have not paid enough attention to when are we augmenting the relationship and when are we interfering or diminishing the quality of the relationship. So we need to look for the distortions, the potential human disconnection, loss of empathy, loss of compassion that some technologies will bring, and know when we're doing that. Here's a great example. Anybody recognize this screen? So if you've heard me talk before, you might have heard this example, but a young man came to see me. It was actually pre-pandemic, but he was fairly depressed. A lot of people I see are, and part of my history when I'm talking with someone who has depression is to do a bit of a social history. So I said to him, who do you have in your life? How many friends do you have? How many people in your life? And he said, 107. And I said, yeah, that's Facebook. And he said, yes. I said, so let me give you a different definition. With how many people in your life can you sit down, look them in the eye, and tell them about how you're feeling? And he said, none. I said, I'm going to choose to say you have 0 friends, not 107. And I have a metaphor that I quite like that I think you might maybe find helpful. So where's my cam? Here it is. I like this. Maybe I shouldn't. It looks like food. It sort of tastes like food. You eat it. But if you tried to live on it, you would die because it's not food. So what I think we should ask when we look at a technology is it creating a compassionate human relationship or is it empty calories? I think that we create relational technologies that are actually the equivalent of diet soda. It feels like a relationship, but it isn't. Or it's a different kind or a weak relationship. For a depressed adolescent, the friends on social media are pretty close to the equivalent of diet soda for many of them. Not always, and I'm not demonizing social media because there absolutely are ways in which it can foster connections. I'm going to say right now very clearly, I'm not humans good, technology bad. Definitely not. Humans can be very unempathic, very cold and very disconnected, and technology can be amazing, but not automatic. So before COVID, we started spending time thinking about this. This is Alika Lafontaine. I don't know if you know Alika Lafontaine. He's a very gifted Indigenous leader, and he and I had a podcast we did. It's a bit of, no one makes any money out of this. You might want to listen to it. It's just pre-pandemic. He and I were talking about how you build virtual relationships. He has a lot to do with the Saskatchewan Health Authority's virtual program, and I was interested in this because I wanted to know how colleagues are learning to work over virtual platforms to build connections, particularly with Indigenous peoples. I mean, that's a challenge. I've worked in the Arctic and had to try to learn some of the cultural humility and the ways to not make eye contact and tell stories instead of directive information and whatnot. So I was interested to talk to Alika about, okay, now you're going to add virtual into that, and I'm going to try to do a compassionate consultation with someone 2,000 miles away, but good luck. So it's an interesting conversation. But I have to say it was primitive in those years. It sounded like I was in the Second World War. It's only 2 years ago, but we were very early in, I think, I'm generalizing, but I think I know the literature fairly well. People were talking about stuff like this. Like, you shouldn't probably turn your back to your patients. It'd be better if you sat beside them and looked at the iPad. And this was a kind of state of the art, how do you use your technology compassionately that we were talking about before COVID hit. And COVID has accelerated the move in unbelievable ways. So we're a chief medical officer in UHM. We have 1 million outpatient visits a year. Before COVID, there was almost nothing that was digital, like almost nothing. In 3 weeks, 85% went virtual. 3 weeks of 1 million visits a year. And we're still hovering around 65, 75%. We're not going back. We will go back, but now we're asking what should go back, when, for whom, how. but it was like radical. That could never have happened. We've been trying, David, who wrote the chapter, said, we've been trying to get doctors and nurses and others to do virtual visits for 20 years. Nobody would do anything until COVID, and then overnight it went. So we have a natural experiment going on, but we're way past here. So I want to share with a little bit of emerging research group. This is a group that is multidisciplinary. It's very much Wilson Center. TIER, if some of you know that, that's our new research institute at UHM, the Institute for Education Research. It's we decided we needed a platform to augment the Wilson Center so that we could have access to some of the sources of funding not available to centers like CRCs and other things. Anyway, TIER is a fantastic research institute headed by Nikki Woods as the first woman research institute director of a UHM research institute, which is amazing, and Sick Kids Hospital. So some of these characters you probably know, some of them you don't, some of them are clinicians, but they've started to do some emerging research, and they've spent a year reading about, observing, interviewing, looking at people's experience of digital and virtual in COVID to see what they could learn. So this is not published yet. And so I got permission from them, and I made triple sure they were okay with this, because I'm going to present you a little bit of, yeah, it's okay. But you know, maybe I could invite you, if you're interested in this work, to follow up with the authors about the work that they are continuing to work on. And for that reason, I'm not presenting everything, but I'm going to give you some themes that they were kind enough to share. All right, so as I mentioned, a lot of work here: clinicians, patients, learners, administrators, documents, literature. They focus on a few areas. They've been looking at rehab, pediatrics, mental health, oncology, and education. So it's a pretty broad brushstroke. And here from Robert is a quote: "These are early days. There is definitely an awareness that communication, professional competencies, and identities are going to be different. However, the breadth and impact of what those changes are going to be is unclear." And I'll share a bit of what they think, but they found that people have been quite discombobulated by this rapid shift to virtual and are having trouble picking out what parts they like, what parts they don't like. Is it good? Is it not good? And I'm going to share some of those observations, but I think we really need to think about it. And you can guess I'm going to tell you that we need to think about it with a compassionate lens. Not just is it good or not, but based on what criteria? Okay. So for patients, probably not surprising to you, some of you probably are patients, and some of you may have used virtual care, as I have for myself during the pandemic and for my family. Patients in general tend to value it. Generally, they find it a positive thing. But what we've learned is an awful lot of complaining about what we used to do, about how horrible the model was before. The great example I used was the congestive heart failure. Someone said to Heather, "Are you kidding me? I used to get in my car in Oshawa, drive to Toronto, pay $25 for parking at Toronto General Hospital, wait, have some mean person at the front, and go upstairs and wait, and then you'd be late, and then you'd see me for 3 minutes, and then the nurse would weigh me, and then you'd write me a paper prescription, and you'd send me to the pharmacy to get my, increase my dioxin or whatever, and then you'd come back, and then I would get in my car, and then I'd drive home. And now I can call, and you've already got my weight from a sensor, speak to the nurse, and the pharmacy sends me a script, or they just deliver it to my house. Why wouldn't I like that better? What were you thinking before? Like, right? So this is the kind of attitude that many patients describe. However, being present is an issue. People multitask, right? You guys are multitasking. I'm good with that because I think you're probably multitasking about the talk, but maybe not. Maybe you're talking to your kid who, is getting home late, or your mom, they screwed up her appointment for her 4th vaccine dose and you're trying to figure that out, or oh God, we forgot we got dinner on Friday and honey, can you cancel the whatever? And so we're all multitasking, but guess what? We're multitasking when we're in the clinical space now. In psychiatry, the sanctity of the psychiatrist's office is we get together and we look in each other's eyes, and I'm the patient and you're the psychiatrist, and we don't go on our phone and start, playing Tetris or something, or whatever you play now. So it turns out patients and clinicians are multitasking during virtual care. And that has some implications that we have to think about. You all know that students multitask during virtual learning, right? Very interesting. So this presence thing is important, very important. So we have to be careful that we understand what we're doing if we're conveying presence or not. Probably wouldn't be good if you were multitasking on your email while you were on a virtual talking to someone who was dying. And that is something I'll come to. Okay, clinicians. The communication experience is quite new. I had done some virtual consults in the Arctic, but I had never done psychotherapy. I had never done treatment. I had never cared for my patients over virtual. I've learned how to do it now. I was really not good at it in the beginning. 2 years later, I'm better at it. Some of my patients like it, some of them don't, but it's a learning curve. And if you asked me, as people do, is it good in psychiatry or not? I don't know. I think it's good for some people. I think it's not good for others, but I don't really know. And most of the clinicians, those of you who are clinicians, are probably thinking the same. I think there's something good in this sometimes, but not all the time. And this is very unclear. So virtual does something. It focuses the attention on the patient and the patient on the clinician. And that may be helpful, or it might be very unsettling. You notice we just had a session for the Karolinska Institute Fellows, and we had a tutorial from a BBC newsreader. And she said to us, you must look at the camera. This is what all journalists do. She said it'll feel weird and you'll hate it and you're going to try to make virtual eye contact with the person's head on your screen, but you can't do that. If you actually want to empathize, you must look into the camera. So like I'm looking at Jonathan now, like, right? I'm looking at you, no, I'm not. So it's very weird. It does look way better, but if you're someone trying to build an empathic relationship over digital, you have to look at the camera. And then you got to figure out how you can look in their eyes occasionally to see if they're crying or they're reacting or something. Very weird, very not normal. Also, patients are more informal. And we've heard from this research team, I'm taking no credit for this research. Some of the clinicians are really distressed by the informality of patients, showing up in their tracksuit, doing their consult in their car. As one said, the sanctity, the formality of the consult is gone. I feel like I'm talking to the cleaning person. You know, one of my colleagues said, I really hate medicine now. I feel like a telemarketer. I just put on my headphone and I feel like I'm doing telemarketing. Like, where is all the dignity of the medical consult? So this is something that we have to properly. So here's another quote from Robert, from the team. Moving into the virtual space seems to be erasing the moments of transition between places, meetings, and types of work. The moment of getting from A to B, those in-between moments that allow for a shift in headspace. Losing this has effects. Entering into a virtually created space seems to erase an awareness of context, of difference that people get from being there. And I would add, for my colleagues who are suffering widely from burnout and distress, it also erases the hallway conversation where I say, how are you? One of my colleagues I did at the elevator just a few weeks ago, and she burst into tears. I didn't know that her father had died. I didn't know that her marriage had broken up. I mean, I was horrified, and she was crying in front of the elevator. But normally we would have these conversations weeks before because we have a relationship, and you don't do that over Zoom. So I'm going to just, in the last 10 minutes before we go to some discussion, I want to talk to you about things we learned in the pandemic. Everyone has pandemic stories, and I'm sure all of you have pandemic stories, both personal and professional. And I know that some of them will be profound and some of them will, almost everybody I know has had some degree of distress or trauma. And so I appreciate that. And this is not necessarily a trigger warning, but I will tell you that some of the experiences we've all had have been tough, and I'm not, sugarcoating some of the ones that I've seen. The first was long-term care. I had a lot to do with long-term care. In Toronto, the homes went into a downward spin very quickly. And we were involved in an article, this is from the Toronto Star, but one particular home called us in very significant distress. You don't need me to recount what that was like. Some of you were probably involved in this. You know the story. the place where one PSW is caring for 300 patients kind of thing, and the people have fled, and it was difficult. So our hospital was asked to help. We had no relationship with long-term care homes prior to COVID. In this particular home, we sent in 1,500 shifts of staff. We put showers in the parking lot, and we sent PPE and taxis, and we all went and worked, most of us as PSWs. They didn't need a lot of doctors and nurses. So this is a picture in the mask. That's Dr. Catherine Tinkham. She's our physician in chief now. She went on the first day and started doing 12-hour shifts as a PSW, and many of us did that. So it was really interesting because in this work, and this was in the darker days, things got much better later. What we started to think about was relationships. This is the CEO and the medical director of the Rakai Center where we went, which was the first home that went into a real crisis. And one of the first things I talked to them about, I said, well, who's been helping you? And this is meant with no criticism at all. I think the intentions were good, but 2 other hospitals had been trying to help them with virtual. And actually, one of my colleagues in one of the hospitals was irritated with this home and said, well, I don't know. I mean, we've got a perfectly good virtual system. They just won't call us. And I said, you know that there's like 1 nurse for 300 people. Like, nobody's going to call you. So I think it was just an eye-opening thing for me. And I wanted to illustrate it, and there's several slides we'll illustrate. This is our team that went in that first few days. This is students, health professions of all kinds, researchers. Nobody knows who's anybody, and everybody went in to help. It was really this amazing experience for us. But it really, really got us thinking about this. And, you know, long-term care has stabilized. I don't mind sharing a little. Both of my parents died in long-term care during COVID. And I don't think virtual has a huge place. I think it's an overextension of a technology that is mostly not useful. And yet some of the professions have really pulled into, well, we'll only see you virtually. It doesn't have no place, but it's probably not the best and most compassionate example of the use of a technology. But here's something else we saw. If you know much about does anybody work in geriatrics or long-term care here? Okay, if you know this file, you'll know that the problem was not the vaccination of the patients. I never met anyone anywhere, and we gave 400,000 vaccines, we'll come to that. I never met an old person that refused, not one. There was no such thing as vaccine hesitancy over 80 that I ever saw. It was the staff. So what we found when we were in the homes was the risk to the homes wasn't the patient, wasn't the residents or their family, it was the staff. Because huge numbers of them were refusing to have vaccine. So this is me vaccinating, and that's a kitchen worker in Rakai. And what we realized was the on-site presence, never mind virtual for the patients, the issue of the relationship was building a relationship with the staff. So this is the curve. This is Toronto. This is Ontario, and this is the deaths and COVID cases in long-term care. The red arrow is where we started vaccinating, and the bottom arrow is when we stopped the vaccine program. But what you want to see there is that's the staff and the patient numbers. So what started to happen was we realized that virtual was not only missing the opportunity to support the patients, but it provided nothing for the staff who needed to have the physical presence of college. And this home reached 100% vaccination of staff. I think first, we brought in, people had questions. We brought in priests. We brought in, we had community events. We answered their questions. We built trust. We built people from their communities. And so that was really, really important. So what I learned is in-person relationships were really powerful and really necessary. And this was my first, this is wave 2 or 1 or whenever this long-term care thing was. It really got me thinking about the visible difference between when you need to build a personal human relationship and when you can build a virtual digital one. Okay, so deployment, redeployment. Did you do this here? Did you all get redeployed to do things? I'm a psychiatrist, but I do have a general license, came in handy when I was on COVID ward for a few weeks, taking care of patients myself. That was an interesting experience. And we did a lot of redeployment in Toronto. And what really started to become obvious here was the role of virtual education. You probably did the same, where the schools went from all in person to all virtual. Yeah. And it was head spinning for our students. So, I mean, again, like patients, we did a bit of virtual, but not very much. So we really, really learned how to do that quickly. But it just took off, like everything was virtual. This is Jaspreet Singh. She's one of our Michener students. She's a respiratory therapist. We petitioned the government to get to sign off the competencies early so that Jaspreet and her colleagues could go work in intensive care. And we signed their papers a month early so that she could take care of COVID patients. Imagine, right? So the anxiety. So we did what we could. The faculty, this is Martin doing, do you know the chocolate pudding thing? Did you do that for teaching people how to do PPE? Oh, you didn't? Oh, you put chocolate pudding all over the person and then see if they can get their PPE off without the chocolate pudding showing up on their hands or their skin. Oh yeah, try it. That's how we train PPE for everybody. It's actually really cool, but it's pretty alarming how much chocolate pudding ends up on your hands when you take off your PPE. So we did a lot of live stuff, but you know, we started to realize that the teachers can't be there. Martin couldn't go stand beside Jaspreet in the critical care unit. So this is the opposite, where we realized we needed to hurry up with some virtual presence. So this is me, that I'm on the right there, I was redeployed. But this is what happened to hierarchies. On the left is Ryan. Ryan's a new grad GIM doctor. And Ed Cole is the just retired physician-in-chief. And poor Ryan got assigned me and Ed Cole to run the COVID unit. Can you imagine? I'm sure he's like, oh, psychiatrist and a retired physician-in-chief. Great. Anyway, Ryan was lovely, but Ryan said, what do you guys know about COVID? He's like, okay, you don't know about COVID, we can fix that. Brian, what do you know about medicine? Well, I did a rotating internship and some on-call in the 80s. It's like, can you do an insulin sliding scale? I'll look it up. Okay, so we built COVID care learning very, very rapidly over 10 days. It's still there if you want to use it. 192 hospitals used it, and it's a very robust platform for people being redeployed. It has modules like, do you need to use a ventilator? You've never used one? This is how they work. It's got all kinds of introductory modules. The military used it for their redeployment into various settings. So maybe some of you saw it, I don't know. It was widely used, and we kept adding module after module after module. And I realized the opposite of my experience in long-term care, which was we were desperate for virtual support. Absolutely desperate to have someone available. You know, I was literally digging out my old textbooks to figure out how to do general internal medicine before we built this. And so people told us it was extremely helpful to have a just-in-time available source for virtual. But more than that, we put our librarians in cyberspace and available to all the clinicians with any questions. The librarians were running real-time literature searches and answering clinical questions for anybody that was redeployed anywhere. And this was extremely helpful. I mean, I remember one of the early ones was someone said, does it matter if you lose your sense of smell? Is there any evidence of that? So it's being discussed. And the librarians did a literature search and came back with the results of the first evidence that the sense of smell was, in fact, related to COVID. And they were amazing. This was part of my job, was to reorient them, and they were virtual, and they know how to do virtual library, but they had never done virtual support for clinical teams. So this was the opposite example where virtual was absolutely amazing. But we've all had to learn how to teach, and you're probably all doing this now. Like, how do we do this? So back to Robert and David again, just some observations. It looks like when you're teaching virtually, it has some advantages. Students that have had experience with non-clinical virtual platforms seem to have transfer. That's probably, Jeff and this cognitive scientist, probably not surprising that if the transfer would exist, and it does appear to exist. No good for me, the old folks that never used anything digital or virtual, not much good, but for some of the students it's transfer. It also appears that communication skills and some critical thinking is actually maybe enhanced, maybe even more drawn on in the virtual space. Also, it's good for evaluation. You get a lot of observers, a lot of people online. It makes it easier to do that. And feedback, video review, that's all enhancing things. However, like with the patients, it turns out that learners need, it appears, need to have a solid base of relational experience with real patients before they can effectively do it virtually. It looks like it may not be that effective to learn to care virtually if you haven't cared in person. And that's going to be a challenge for us. The second thing is there's this learning plateau. The teachers are really clever with what they can teach virtually, but you run out of stuff you can do virtually. And at a certain point, the teachers are saying, we just got to go to the real clinic because I can't do anymore virtually. I can't make any more things happen. So that's going to be a challenge for us. Okay, last example, then we'll stop at team vaccine. I'm very proud of team vaccine. I say this in a nice way, but it became very obvious to us that the provincial government had no plan to administer vaccines to anyone. So we decided to set up vaccine clinics. And in the end, the UHN and the team vaccine, we gave 400,000 vaccines in Toronto with partners. Here's the first team that went into long-term care. And I pulled out my camera, and if you go on my Twitter, you'll be like, what happened to Brian the educator? It turned into Brian the vaccinator. So there's like thousands of pictures of me with team vaccine. But what I realized was something amazing was unfolding. This is the family medicine, family health team went into the first long-term care home and gave the first shot in Canada to a person in long-term care. It was a Moderna shot. And it was a really great experience. But I started to realize something. There was this joy thing happening when we were getting together, and the team started to say, thank God for this vaccine campaign. I get to see other human beings. And people started to sign up, like all kinds of different people. They would ask us, can I get the training to go with vaccine? Because I want to go into long-term care homes. I mean, in one home, we had to change our PPE between every patient. There were like 75 in their hands with people eating and stuff. But people were so excited to do something with other people. And the students, this is a resident in family medicine, they signed up in droves to come and work with their teachers, vaccinating. This is a pharmacy student with her faculty members drawing up vaccine. This is a nurse teaching a family medicine person in one of our downtown clinics. And what I began to realize at this point in the pandemic was how starved people were for human contact with each other. And then my colleagues that were having more burnout, it was getting worse if they were not having chances to interact with each other. However, again, not to demonize virtual, all this was possible because we had this virtual team vaccine. These were the people who met every single day and worked entirely virtually and supported the team on the ground. We're not used to this model. This is the NASA model, right? The astronauts are in the rocket, but the NASA command, like way back to the 60s, is helping them. This model has not existed in medicine. It exists now, but it's new for us. So this is day 2. This is Doreen Bible. She's the woman who got the very first vaccine in Canada. And this is a picture of the vaccine she got and of Eugene O'Brien giving it. And on the right is our nighttime session. I'm at the top taking the picture, trying to bridge from the virtual team to the real team so that the two were connected with each other. And we brought them all together at the end of every day in cyberspace so that the virtual team could talk to the real team about their experiences and that they would bond. And that became really important. But I realized this was a practice that I'd never seen before in medicine. We don't have mass all control centers in the operating room that is getting online, or the emergency department or psychiatry. So I think what we're going to most need to learn coming out of COVID, we're not getting rid of the virtual teams or the real teams. Everything's going to be hybrid, right? Those folks here we are. But how are we connecting with those people? How are they connecting with us? They don't just, it's not fair to give them just an impoverished TV version of what's going on here. Or for you not to understand what they're doing. They're all multitasking. Some of them are doing a lot of other things. Well, you have to watch me and pretend you're paying attention. They don't. But there's cool stuff going on out there that is not going on in here. Teresa knows this, all the people that started with Twitter, because you're having a virtual parallel conversation that I'm not aware of, but that's okay. But how do we bring all those worlds together? Okay, so finally, I'm at the end. I just really want to say a few points about what now. This really bothered me and a lot of my colleagues. The College of Physicians and Surgeons of Ontario issued this. Is anyone in family medicine here or out there? Yeah, okay. So I don't know if it bothered you, but my colleagues were very upset. There are limits to what can be done virtually, and the standard of care is often difficult to meet in a virtual care environment. While physicians are ultimately responsible for determining the appropriateness of providing virtual care in the circumstances presented, it is important to remember that the standard of care must always be met. In-person care is essential for certain conditions and services where physical assessments are necessary to make So, my colleagues who were in that picture in long-term care homes vaccinating were also running their virtual clinics. And Camille Lemieux, who's the head of family medicine, said, I cannot believe the college just said the standard of care is difficult to meet virtually. That's a lot of, The question is, when can the standard of care be met appropriately in person? And when can the standard of care be met appropriately virtually? Because I would argue there are times when we are not meeting the standard of care in person and doing a better job virtually, and vice versa. So I think this was unfortunate. And I know that there was a whole thing about some family doctors didn't show up at the office for 2 years. And I think that's greatly exaggerated. Every family doctor I know worked incredibly hard during COVID to find a hybrid model. So we need to ask now, like for patients, was it ever good care to make someone drive an hour, pay $25 parking, get a 5-minute? Was that ever the standard of care? And as we go into the OMA negotiations, I think we need to tell our colleagues that they need to spend some time thinking about how the fee system rewards standards of care, not models of care that are convenient or not convenient. We've got a virtual emerge department now, collaboration of St. Mike's, UHN, Sunnybrook, and it's working extremely well. It's not perfect, but there are definitely times when you can meet the standard of emergency care. I don't know, John, if you agree or not, but in a virtual environment, not all the time, of course. You have one too. But I'm going to tell you that there are times when we have to do that. And there's some red lines, and I think we need to draw the red lines. And I would say dying is one of those red lines. Participated in this podcast. I don't know if any of you had to do this, saying goodbye on FaceTime or from an iPad. I never want to do that again. I never want to see that. The departure of a loved one should not happen virtually. I don't think so. I don't think a lot of consents to organ donating bodies, etc. There's things that should just never happen. And we should draw those red lines. For learners, was it ever right to have learners, students, staff traveling across town to hear prepackaged lectures? Hard to argue now, I think. But there are times when they have to be present. We did an awful thing in Toronto. We canceled all the nursing placements for a year. We are screwed now. Our nursing pipeline is really dried up, and we should not have done that. We should have said, we'll make you safe, we'll create opportunities for you to be safe, but this is part of your learning. And this is Jennifer Price from Women's College with her nursing students, and out of desperation, she brought them to the vaccine clinics and said, I want to get you graduated, so we're going to figure out stuff you can do so you still graduate. Power to her. But I think we got to remember there's times when virtual just can't replace the in-person. So in closing, you know what? Technology, knowledge is important, technical skills is important, but if we ever let caring and compassion slide out of the frame, I don't think we're necessary. Without that piece, it's not really healthcare. It's some kind of engineering or technical activity. There's light at the end of the tunnel. These are patients. This is a picture I took. The whole underground parking garage was pouring rain, was filled with thousands of people lining up to come to our vaccine clinic. And I just thought this picture was so amazing because it just showed. It was at Jane and Finch, an area where people claimed there was vaccine hesitancy, but I didn't see too much vaccine hesitancy. I saw a lot of motivated people. And close with this slide, because I think the main overarching purpose of this is that you made an effort to get together. You were kind enough to invite me. You came virtual. You're together. I think the psychiatrist in me would say you need to be together more and learn how to be together again. And I just want to say thank you very much for inviting me to come talk together. I didn't leave as much time as I should have for questions, but there may be a little bit of time.
Yeah,
okay, wow.
I'm sure you can facilitate your own.
I can probably facilitate. Any questions from here, or the Samantha is working with the live studio audience. Comments or questions? Professor.
Yes, Jeff.
I'll review your question for this. Yeah.
I was trying to sit up in the corner and watch this. I think it's probably the case that for the last half of the talk, word compassion, which may never happen. I think we did a bit of a flash on this. We started talking about virtual versus face-to-face and so on. And that struck me as thinking on it. Compassion still has a sort of a visceral quality to it. So my question to you is, can you be compassionate without being empathetic? You have to have empathy as a kind of substrate.
Yeah. It's an excellent.
Otherwise, you're faking.
Thank you, Jeff. Excellent question. For the folks that can't hear, this is another tool that you need to do. Just reiterate. So I think there's two questions. One is you making the observation that I introduced compassion and then didn't use the word in the second half. I'll come back to that. And then the more technical question is, do you need an empathic substrate before you can be compassionate? The second one is easy. I don't think empathy is a sense. It's your eyes see light, your ears hear sound. Your empathy detector has to be on for you to be able to act in some compassionate fashion, because you have to understand what are you directing that activity to. You can't reduce suffering if you don't perceive suffering. So I think that empathy is essential. I have said, though, that empathy can be a problem. Sociopaths are very empathic. Just the ability to feel and experience someone else's emotion doesn't mean you're going to do something good with that experience or that skill. So empathy alone, there's some books coming out actually critiquing the idea of empathy alone, just feeling. But I do think, Jeff, yes, I think that empathy is a foundational experience. I guess I'd call it almost sensory, emotional sensory, that you have to have before you can act on it. Otherwise, you're acting blindly. You're acting on the basis of guessing what another person wants. You might get it right if the person tells you what they need and you act on it and you feel nothing. That might be compassionate, but unlikely. I didn't use the word compassion for a reason, because I hope it was clear, but I wanted to illustrate that what I'm asking you to do is look at every instance of technology and ask the question, is it augmenting the compassionate purpose we're trying to achieve, or is it interfering with it? So I sort of, I don't know if others observe that too. It's interesting. I hadn't thought of it that way. I feel it's not necessary to call it out. When you look at my long-term care example, I think you could see, hopefully you would see, I don't think that the folks that meant well, but were attempting to provide virtual consultation to dying people in long-term care, that's not compassionate. They meant well, and they probably felt empathic, but the technology was not augmenting anything that was compassionate. On the other hand, the educators who created, the librarians who were there, compassionate librarians, a librarian that would take my call if I needed to know something from the ward because I was freaking out because I'm a psychiatrist caring for COVID patients, very compassionate. It was a technology that aided my ability to do that. Does that make sense, Jeff? Yeah, kind of, sort of.
Sure.
Yeah. Teresa. Could I compare? Yeah. So the question is, can I compare my anchoring this around compassionate with human-centered design? That's great. That's a great question. I'd never thought of that. Let me try an example. Ergonomics would be human-centered design, for example. So I could design this chair so that it would be ergonomically designed for a human to be comfortable. So the engineering of technology, this microphone was engineered so that it would most effectively convey my voice to you. That would be human-centered design. I guess what you would want, what I would ask you, and I don't know how you feel about this, is that would be necessary, like empathy, but not sufficient. That technology would not have a compassionate function unless a human using it had a compassionate goal for it. I think that might be my distinction. And this is where, like, let's take the Holy Grail, electronic patient record. Yeah, right. Yeah, like, is it, often not, often a disaster, but like, yeah, I mean, Michel Foucault said, I'm not saying everything's bad, I'm saying everything's dangerous. I mean, water can kill you if you drink too much of it. So any technology can be bad. even if it's well-designed. In fact, a lot of really well-designed technologies turned out to be hideous in terms of their utility. So I would say, I'm making this up as I'm going along, I don't know if you agree with me, but I would say the compassionate function is a question that the human user has to ask themselves. Am I enhancing compassion in my caring? And remember, compassion is reducing suffering. Am I reducing this person or the system or this institution suffering by my use of this technology? If not, it's not compassionate. It might be efficient or something else, but it's not compassionate. Yeah. Any other thoughts? Is there anybody out there in Cyberland?
There's a comment and 2 questions.
Yeah, great.
So the first comment, how crazy is it, or would it be to conceive of certified hospitals and compassionate care? The same idea was a great booster for pain management in the past, I believe. This
is a really good question. So the question was about how crazy is the idea of certifying hospitals as compassionate. So again, the book, I don't make money from mentioning the books. I think I'm allowed, my ethics department has told me I can mention the book without it being a paid announcement. There is a chapter in it called Compassionate Institutions. And it does draw out the qualities that would be associated with an institution that's compassionate, because compassion is not just about people individually. And this is something I worry about a bit with the Royal College, that I think sometimes we think about everything only in the health provider patient relationship. I mean, there's some hideously uncompassionate institutions with really nice people working, and they may even be in a single instance very compassionate, but maybe the institution's not. The closest I've ever seen is the magnet hospital movement. Does anybody know the magnet hospital movement? So there is a movement called magnet hospitals. I think Mount Sinai in Toronto is one. And you can join, and there's certain criteria about things that the institution must do. And magnet means that it attracts people. They also have much higher retention of staff. They have lower turnover, they have lower burnout, and they're defined criteria. We've talked about this at AMS, about whether we could have some kind of award or certification, or I would rather the accreditors that exist build this in. You know what I would love to see would be Accreditation Canada, Royal College, people that when they're doing their work, they would ask this question. Is the criterion of compassionate care embedded in the institution? But I'd go further. I would say that the certifiers of technology should be asked that too. And this is where the electronic patient, I had an arm wrestle. We're getting a new electronic patient record system. And I said to the companies as they were auditioning, you need to explain to me how this is compassionate, not only for patients, but for clinicians, because I know the burnout literature. So help me with what your company is doing. I think that's been a missing piece. Yeah.
What is your favorite tool to measure compassion in the clinical/research field?
Ask the patient. My favorite tool to measure compassion is to ask the patient. And I'll give you an example. Again, I'll use just for my own practice, because I'm really struggling, like all clinicians are. When does it help my patients and when doesn't it? So I've got some, and it's not age dependent. Some are old, some are young, that love the virtual. In fact, one of my older, she's an old woman in her 70s, and she said to me, Brian, I really hope we can keep meeting this way when this is all over, because she has trouble with mobility, and she's so reassuring. I can just turn on the thing and there you are, and this is amazing, and I really hope we can do that. And I think it's very, very compassionate. So, but on the other hand, I have another young man who said, I really appreciate what you're doing, and this is really helpful and stuff, but there's something missing. Like, when can I come back to the office? But I've also realized that it's not just the virtual. I've become quite good at text with patients. Now, not all my colleagues love this, but I do text them, especially the ones with suicidal ideation. And I've worked out very carefully and very thoughtfully when this is appropriate and when it's not. But a two thing that says, "Are you okay?" can be super compassionate and helpful. And I'll also say to somebody, like I do with medication now, I said, flip me a text 24 hours after you start this new medication and tell me if you're okay. Any side effects? I think that's very, but I think the answer, thank you for the question, I'm looking at the camera, is you gotta ask the patient. And I think for learners, I think we should also ask the learners. And like, not just, did you like this or not, but are you learning? Are you building relationships? Is this good for you? I think that's the only way we can know. Is that the end of the questions online? And I think, Mr. Boss, I should be compassionate and let you move on to the next part of the, anyway, thank you very much. I really, really appreciate it.
Thanks so much, Brian. Wait for you to turn your back and get fully masked and get all connected. I got to tell you, I was really challenged as you were talking. I saw myself in many of those instances. I was challenged to think, have I lost some of my compassion because of the arduous nature of the pandemic? I think that maybe on the, what I feel is the other side. I understand that we're not done. We still need vigilance. I'm optimistic for the return of some of that compassion. In small moments like this, where I get to connect with colleagues and talk about these ideas, be challenged here, that is part of the vaccination to rejuvenate my compassion immunology. I'm trying to mix the metaphor back to COVID in a way that works for me. So thank you for challenging me there. I'm sure we'll have a lot of opportunities to talk to Brian and talk to each other about some of the themes and ideas that have come up. I want to transition to the final portion of the Sibley lecture, which is the Sibley Award, before we end with some light refreshments at the end of our day. The Sibley Award is in remembrance of Dr. Jack Sibley, who first appeared at McMaster around 1967 as an assistant to the founding team. At the time when he was becoming involved with the incoming in the new medical school, he was the head of the Department of Medicine at Joseph Brant Hospital in Burlington. And his responsibilities to the medical school initially were on a part-time basis until he joined full-time later. Dr. Sibley was involved in developing a cooperative program between the Mohawk College and McMaster University for teaching physiotherapists and occupational therapists. He was the chair of the Health Professions Education or post-professional education program at the Faculty of Health Sciences, and oversaw the development of the nurse practitioner program, clinical behavioral sciences, and a number of other programs. Subsequently, working with Dr. Sal and Len Levine, Jack Sibley organized the educational resources for all postgraduate programs. And so you can see in this legacy a significant and important contribution to educational programming that will become part of the Faculty of Health Sciences at large. John C. Sibley Award for Excellence in Education for Part-Time Faculty recognizes the following fundamental dimensions: development and evaluation of innovative educational activities in the health sciences, support of interprofessional education, sustained commitment to the academic mission, and impact on teaching and learning in Faculty of Health Sciences programs and initiatives. This year's recipient meets all of these criteria and surpasses them in many ways. So please join with me in welcoming and acknowledging the work of Dr. Catherine Munn. I'm so pleased to see that Dr. Munn is the recipient, and as you hear more, just a snapshot of what she's done, you too will equally realize the important contribution she's made to the success of our faculty. Dr. Munn has been a faculty member in the Department of Psychiatry and Neurobehavioral Sciences since 2001. In that time, she's had an impact on the university, the faculty, and specifically with regard to student mental health initiatives. She's been an investigator or co-investigator on grants worth more than $2 million, including several large CIHR awards that study the impact on programming that she and her teams have developed to support student mental health. Dr. Munn has participated in the development of programming in several of our faculty initiatives, including her role as the Assistant Dean of Resident Affairs in Postgraduate Medicine, a long-time facilitator for the Professional Competencies curriculum in the undergraduate medical program, and as a curriculum co-developer in a Bachelor of Health Sciences Praxis Pathways curriculum, exploring self-knowledge and self-care in challenging times. At the university level, Dr. Munn created the Professor Hippo on campus. It's an insider neurosciences joke, which is exactly that, insider neurosciences joke, of modules to train faculty and staff to build knowledge, skills, and confidence to support student mental health. To date, in our faculty alone, more than 1,200 faculty and staff have taken this program, which is being expanded to other post-secondary institutions. Out of the Professor Hippo work came the development of a video series titled, Are You Okay? An initiative to support first-year university students communicating with their peers in difficulty and distress. Please join with me in celebrating Dr. Catherine Munn.
Thanks, Jonathan. Yeah, it's the first time I've been in front of like a real audience in some time. So I found myself at a bit of a loss for words, I think. Also, I only found out about this yesterday, so I didn't have much time, so I won't take much more of your time. But I really do want to just say thank you to the group for honoring me with this award, and particularly to the people that actually nominated me for this award. I have to say that is one of the more heartwarming things that has ever happened in my career, and just to have the breadth of people that were part of this nomination is just really motivating and inspiring at this, kind of dark time. Honestly, I think we're all pretty tired out from a healthcare point of view and from an education point of view. Talking to black Zoom boxes and in rooms is difficult, and doing virtual care is difficult. And yes, there's some compassion to be found in these places, but sometimes it's really hard to see. And so I think, yeah, I just really value the colleagues that nominated me, and they include Dr. Nick Cates, who's the chair of the Department of Psychiatry, and Dr. Parveen Wassi, who I'm just so privileged to have. I like to say it's sort of my first boss in postgraduate medical education here. And also Dr. Sarah Kinsey, a family medicine program director, who I've just been so fortunate to work closely with for the past couple of years particularly. And then a PhD candidate, almost Dr. Jillian Halliday, who I've worked with since she was a second-year nursing student, so for about 9 years now. So it's I just really want to thank those folks, and also all the other folks that I've had the good privilege at McMaster of working with, several of whom are here, some of whom I've never met outside of Zoom, actually. I'm like, I'm pretty sure that's her, but we never met off camera kind of thing. So yeah, I mean, I think I've had the good fortune, and I think probably unusual privileges as a health professions person of working with faculties all across the university. So because of the work that I've done in post-secondary student mental health at McMaster as a clinician, but then also kind of more administrative and research wise, I've had the good fortune of working with people from all of our 6 faculties. So from humanities, from social sciences, and really understanding their lens on the world of mental health and well-being. And I think also, like, how do we create compassionate healthcare, but how do we also create compassionate education? And like, are we losing that? And are we at risk for losing that, especially in the pandemic? And I must say, I'm quite concerned about that. And I think it's compassion, and it's also more self-compassion. And I think we're all running a little low, perhaps, on self-compassion these days, and we must attend to it. It's like we have to take care of ourselves, or we can't take care of others as educators, I think, and as clinicians as well. And it sort of almost sounds trite, but it's so important to me. And I think to the point of compassionate institutions too, we have to think about, it's really around psychological health and safety. Do we have each other's backs in our institutions? And we can't always say yes to that. And we must be able to say yes to that. Do we have each other's backs when someone falters, when someone falls, when somebody struggles? We got to have each other's backs. So we're nowhere. I think really that's probably all I really have to say. I really do want to thank. I'm so fortunate and happy to have my daughter here with me today. She'll kill me for saying that, but she's a first-year art science student at McMaster. She was the family member that could come, but I as you all know, when you do all this work, it's kind of consuming, and kind of you don't always have the attention that you should in the places that you should, but you try. And so my family has learned more about mental health, psychological health and safety, well-being that they ever would have wanted to know, possibly, but they've been so patient. And I will just tell a little anecdote that when Isabel was younger, at one point, one of her teachers said, well, you really like to read, and where'd you get that love of reading? And I'm a huge reader. I feel like I kind of, maybe I should have just been in humanities doing, I sort of long for that, being able to write stories and things like that. But she said to her teacher that, well, my mom only reads self-care and self-help. And I was like, it's not self-help. She only reads self-help books. And anyway, it's true. I read a lot of self-help books and a lot of books about how to help ourselves and how to be compassionate about ourselves and each other. So she's right, actually. And trying to translate all this stuff that we talk about into terms that real people can understand, students and faculty and staff. And so, yeah, I just really want to thank everyone here and all the folks that across McMaster that have just been incredible collaborators. There's several of you, many of you here that have just given me so many interesting opportunities and just been able to meet so many folks that I would never have met in medicine. And it's just such a privilege to do this work. And so I really, really thank you at this moment for this award. Thank you.
Congratulations, Catherine. You have done the Holy Grail. You've been recognized for your contribution to our faculty. You've been here to celebrate with us in person, and you've been able to embarrass your daughter in a live studio audience rather than over Zoom. So thank you for that. Before we leave, two forthcoming events I want to flag for you. The first is May 17th, Merit Rounds. We'll be having one of our new merit scientists, Dr. Ela Biljik, who is here presenting on her program of research. Dr. Biljik is a faculty member in the Department of Pediatrics and a merit scientist. And then on June 8th, it is the Norman Education Research Day with Dr. Andrea Gingrich, who will be presenting the plenary presentation. So please come out and join us for the most aptly named research day ever, the Nerd Day. With that, I'd invite you to some refreshments, and thank you for attending.